guys, this is Alicia with Good Morning Sunshine. So today we had 4 lectures. We're on week 6, day, what's today, Tuesday, day 27 today of vet school. So yeah, we have 4 lectures today, 2 labs. It's been a long day. I still have tutoring tonight, but we're gonna get through it. So we did physical exam today, had a lecture of the physical exam of an equine. I think we also had a physical exam of small ruminants as well, and then in between we had pharmacokinetics. So that's what my talk is going to be based on today. So first I'm going to start with the equine patient evaluation. So we want to get a history on the patient, and then we want to go into the actual physical examination. So this was over a recorded lecture, so I'm going to explain best of what was given to me. So first, we want to stop and watch the horse from afar, so just get a visual of it, no touching, no feeling, and this is when you want to talk to the client and get history. You want to look at the horse's body language, so how they are acting, if they're mad, obviously you want to be careful with that. So the top right horse here is a little angry. And then we have the nose flaring, which could mean it might have a high respiratory rate. But yeah, there's all different signs we can see just with our eyes. So history, we want to get a past history and also a recent history. So for past history, we want to know wellness, vaccines, dental care, housing, diet, what the horse does for a living, and past medical treatments. And then we want to get into recent history. So when did problems start? Is it getting worse or better? Are they eating, drinking? And did the client treat them with anything? So stuff like that. So then physical examination, we got like what their temperature should be, what their pulse should be, what their respiration should be. So temperature for a horse should be 99.5, and then a degree above or below that is normal. And then for their pulse should be 36 or plus or minus 10 above and below. And then respiration should be 12 plus or minus 4 above and below. So we want to set a routine of how we do our physical exam. We want to start at the head usually and work around the horse. So there's going to be one person holding the horse, obviously, and then the one giving the physical examination, so usually the veterinarian. So you want to be on the same side as the person who's holding the horse. Wants to be on the same side as the vet who's doing the physical examination. You want to look at the eyes, the nostrils, see if there's any discharge. You want to look at shape and symmetry. The mucous membranes, capillary refill time should be less than 2, and also texture. And then you want to look at the teeth. The teeth actually in a horse gives them their age. And you're going to be looking at their incisors because they lose their incisors at 2.5, at 3.5, and at 4.5 years of age. So again, you're going to start at the head, you're going to observe for symmetry, you're going to look at the eyes. I guess I could show you all of this stuff. So we have all these pictures. So once you look at the eyes, you're going to tap lightly on the sinuses. That should be hollow sounding. You're actually looking at the maxillary and frontal sinuses. And then you're going to check vision for a response, the flinch response. This is called menace. It's a learned response. And then we're going to palpate the intermandibular space, and then for lymph nodes, we're going to palpate the facial artery where it crosses from the mandible. And then we're going to do thyroid also, and then we're going to check the jugular vein. We're going to check for previous history as well in these cases. And then we're going to palpate for the cervical vertebrae on the neck. And then we're going to palpate muscles in the neck, look for the nuchal ligament, and feel for body condition here. And then we're going to go down to the front legs. We're going to assess them for pain and swelling. So this is where we check the fetlocks as well, in the palmar digital artery. And then next we're going to pull out our stethoscope and listen to the heart, lungs, and GI tract. So you're going to listen in all different places, in all different arteries of the heart. So this is the PAM system, where you have the mitral valve, you have the aorta valve, and the pulmonary. And then on the other side you have the tricuspid valve. And then you want to listen to the respiratory tract. You want to put your stethoscope by the trachea as well. And then of course you want to listen to the lungs. This is between the 17th rib by the tubercocci. And then you want to listen for abdominal sounds. There's 2 on the left and 2 on the right side, so 2 on each side when you're doing the physical exam. You want to start at the paralumbar fossa down to the lower flank. And then once you're done with this, you're going to do more of a hands-on exam with your hands. You're going to feel the abdomen for things like edema, and then you're going to feel for their testicles or for their udder. And then you're going to move down the back legs. So you're going to be in front of the back leg because you don't want them kicking you, obviously, and you want to be kneeling. And this is when you're going to take the horse, you're going to get back up, and then you're going to check the horse's temperature. Just make sure you keep a hand on them. Make sure you're telling the horse that you're there, and then you're going to lift tail and take the temperature that way. And then you're going to walk around the horse, you're going to stay close and repeat the whole physical exam that I just told you on the right side. So usually you would start on the left because horses are more comfortable with you being on the left side, so you would want to usually start with that side. However, there's no correct side to start on, but usually people do start on the left side. So you're going to go through again that whole process. And then we got into body condition scoring a horse. So you're going to check around the nuchal ligament, which is in the neck. Here, I'll show you. In the neck here. And then you're going to check for the withers, which is in the B here. And then you're going to check behind the shoulders, which is C. And then D being the ribs, E being the back, and then F being the tail head. You're going to check all these places in order to give an accurate body condition score. Body condition scores are scored 1 through 9. 4 to 6 being ideal, 7 being overweight, and 8 and 9 being obese. So like this horse right here got a body condition score of 6. This horse weighed 1,200 pounds, that was said, but its target weight should be 1,100 because every body condition score is 50 pounds. So this horse would need to lose, I think we went by 7. We used a body condition score of 7. We were talking in the lecture, well, not talking, but in the recorded lecture, they gave body condition score. We used 7 because someone told us it was 7, but actually it was 6, if that makes sense. But anyways, so we use 7. So every body condition score is 50 pounds. So this horse needs to lose 2 body condition scores to be at a target weight. Its target weight being 1,100 pounds. Also, you feed 2% of a horse of its target body weight, and that's how much you should feed your horse. And then at the end, you're going to use weight tape in the heart girth area at the highest point of the wether. So that was the physical exam of an equine. And then we got into the rest of pharmacokinetics. This is the rest of the lecture from yesterday's sitcom. I think I got to oral, but I'm going to start at oral. So oral, or I guess I'll start at reasons for poor oral bioavailability. So drugs not delivered from its formulation to absorption site in the gastrointestinal tract. Water-soluble drugs are enough to go into the solution, whereas lipid-soluble are enough to be absorbed across the whole gastrointestinal membrane. Drug formulations may have solubility enhancers to improve absorption. Drugs must go into a solution before it can be absorbed. And this may be a rate limiting step for lipid-soluble drugs. I think I did go over that in my yesterday's sitcom. The drug is decomposed in the gastrointestinal tract, gastric acid, and rumen microbes. The drug is complex in the gastrointestinal tract, chelate with cations, other drugs, milk diet, supplements, etc. And then we got into ion trapping. This basically means an acidic drug in a basic environment is more likely to stay in that environment because it's ionized or so-called trapped. And then also a basic drug is in an acidic environment and it becomes ionized and thus stays in this environment because it cannot cross the membrane. It is less likely to be absorbed into the stomach. It becomes ionized in the small intestine and will go into the bloodstream, and there it will remain, usually unionized. So like I said, ionized drugs have a hard time crossing the cell membrane, whereas unionized drugs pass more readily. The stomach is so acidic, it can trap drugs, and that's the same with urine. So again, stomach highly acidic, plasma is neutral, and the stomach absorption minimal for most drugs. They need an acidic drug with low pKa, much less surface area for absorption, and most drugs are absorbed in the small intestines because it has a very high surface area. Drugs that need a carrier-mediated transport but don't have one because they're either too big, they are too water-soluble or lipid-soluble, or they're too ionized. For some drugs, a large percent of drugs absorbed is immediately metabolized in the gut or liver prior to absorption in the systematic circulation. This is known as first-pass metabolism. You do not want this to happen because then the drug does absolutely nothing because it doesn't hit the systemic circulation, it just gets metabolized. An example usually of this is opioids. Drugs with a high first-pass metabolism are often not suitable for PO administration, so oral administration by mouth, because they do not reach adequate plasma concentrations. So again, first pass metabolism you want to avoid. So you want to avoid giving some drugs orally because they won't make it to the systemic circulation. So ways to avoid, you want to alter the route of administration. So you want to probably go mucosal or per rectum, but not all drugs are suitable for this. They need to be lipid soluble, they need to be highly potent, and unionized at the mucosal pH. So what is transmucosal? It's an oral transmucosal, aka buccal or sublingual. Membranes are relatively permeable, rich blood flow, and rapid uptake of a drug into the systemic circulation to avoid first-pass metabolism. So transmucosal is usually under the tongue, it absorbs that way. And then we have per rectum, where you put the drug into the bum. So advantages of this, you can access unconscious or vomiting patients, there's no taste, and you can recover drugs before absorption is complete if there's a bad side effect. Disadvantages are limited surface area, lower fluid content, and microbes. Also, too far cranial drains to portal vein through cranial rectal vein, and also drug may not stay where you put it. So transdermal is not the same as topical. Transdermal is drugs absorbed through the skin into circulation. Topical just stays on the skin, is not absorbed. It reaches a therapeutic concentration. So then we got into the pharmacokinetics of absorption. We got into Cmax, which is the max concentration, and then Tmax is the time to get to max concentration. And then we talked about area under the curve. This all goes with a plasma concentration time curve. So here is your time curve right here. So we talk about the area under it here, and then we have the time of maximum drug concentration, and then we have maximum drug concentration here. So again, Cmax being the maximum plasma concentration, it's usually typically highest for IV dosing and typically lower for by mouth, IM, or sub-Q. And then we have Tmax, which is again the time to maximum plasma concentration. Its units are in hours or minutes. For IV dosing, occurs within 2 to 3 minutes or less, and highly variable for by mouth, IM, sub-Q. So here are these. IV drugs is the blue there, and then this is your EV drug, which is everything else. And then the IV again is the highest concentrations occur immediately, then get eliminated over time, whereas an EV drug has maximum concentration and absorbs later. So the area under the curve is influenced by the Cmax and Tmax. It indicates how much drug is absorbed given by the EV route. So again, here's area under the curve, which is this area. The area under the curve is to calculate bioavailability, the rate and extent of absorption, and two types. There's absolute and relative. Absolute bioavailability compares the EV drug to the IV drug and calculates. So, I pressed a button. Hold on. So looking at this chart, this is the question we got. It says which EV drug has higher absolute F percentage. So here we would look at area under the curve. So obviously it's not the IV drug. Obviously it's not the purple here, the drug B. It's obviously drug A because there's so much more area under the curve. So that means more of the drug is absorbed. So then we have relative bioavailability, which compares the EV drug to another EV drug. Maybe routes of administration are different, maybe different formulation and calculations. So then we looked at the top one here. It asks, relatively speaking, which route has higher absorption? So again, you look at the area under the curve, and obviously that is the drug A, which was given intramuscularly, which makes sense because PO would take longer. And it has, oral has more variability. So then, again, relatively speaking, which has a higher absorption, you look at the area under the curve, and again, drug A is a solution, and in green, that is a suspension. So again, the blue one would have more area under the curve, so the answer would be solution. So bioequivalence, we have FDA proprietary versus generic formulations. We have generic versus generic. We have FDA approved versus compounded. So again, which EV drugs are bioequivalent? So usually generic and FDA approved drugs should be relatively the same, should have relatively the same amount under its curve, whereas compounded drugs are down here. So clinical relevance of bioavailability, a drug needs to be absorbed to have an effect. Exceptional would be topical. Low bioavailability, no effect. It requires dose and formulation adjustment. High bioavailability, still better most of the time. There's disease factors affecting absorption, like gastrointestinal disease, enteral versus parenteral. So oral drug administration is not often the best route for GI disease because of vomiting, diarrhea, and proliferated diseases. But what about liver disease? Well, let's talk about giving morphine. So it's a first-pass metabolism. So liver disease can decrease first-pass metabolism, therefore increase oral absorption of some drugs that normally undergo high first-pass effects. Dehydration, unless very severe, will most affect drugs administered via the subcutaneous route, resulting in decreased drug absorption. So that was the finishing lecture of pharmacokinetics, but then we got into pharmacokinetics drug distribution, which is lecture 3 today. So I'm going to talk to you about that. So membrane barriers. It wants drug to work into the tissues. So if you're giving by mouth, you have absorption starting, it has an absorption phase starting with the environment. If you're giving IM and subcutaneously, you start at interstitial fluid for absorption. So this absorption meaning getting the drug into the bloodstream. And then, but if you're giving IV, it totally doesn't have an absorption phase. It goes straight to distribution. Distribution being getting the drug from the bloodstream into the tissues. So introduction, a drug is not inside the body until it is absorbed into the bloodstream. Once a drug is absorbed, it immediately begins to be distributed. So drug distribution, defined exactly, is reversible transfer of drug between the blood and the extra vascular fluids and tissues of the body. So drug distribution. From plasma, drug first distributes into the interstitial fluid, which is aka that extracellular fluid between and outside of the cell. Next, the drug may cross biological membranes to enter into intracellular fluid, protected tissues. So factors affecting this distribution of drug throughout the body is not equal. It depends on drug factors, their lipid solubility, their molecular weight, and their pKa. Also, it depends on the pH of fluid distributed into, regional blood flow, drug binding, so that means plasma protein binding and tissue binding, and then lastly, anatomical structure of the membrane itself. So let's start with solubility. Again, non-ionized lipid soluble drugs easily cross membranes and distribute widely, whereas ionized water-soluble drugs can't easily cross membranes and must remain in the plasma until, I guess, they're small enough in order to go across, or they find a way across. So they usually get stuck in the interstitial fluid. Low molecular weight can cross a membrane easily, whereas high molecular weight can't cross the membrane and will remain in the plasma. This includes protein-bound drugs and monoclonal antibodies. Then pKa and pH. Blood is very slightly alkaline, as it always should be. Its average is 7.35 to 7.45. Acidic low pKa drugs will be mainly ionized, thus limited ability to cross the membranes because they're ionized, whereas basic low pKa drugs will remain non-ionized, thus can cross membranes more readily. And then blood flow. Initially distribute to high blood flow, low volume organs such as the brain, which is lipophilic, the liver, and the kidneys. Next, lower blood flow, high volume organs, it would blood flow distribute to the muscles. And then finally, low blood flow organs, the drugs will be distributed to the fat, the lipophilic, the skin. And also remember that subcutaneous absorption is affected most by dehydration. So drug redistribution, examples be barbiturates and propofol. So propofol is used in general anesthesia where the animal gets put to sleep. So it has a immediate effect, and then slowly the animal will wake up. They go to the brain for effect. The effect decreases as the drug leaves the brain and enters the muscle fat area. Sight hounds have prolonged recovery with these drugs because of their lack of fat for redistribution, and also greyhounds, young animals, and malnourished animals as well. Factors affected, we have plasma protein binding, albumin, which is a major protein that binds drugs and weak acids, and then we have our alpha-1 acid glycoprotein, which have to do with bases, weak bases. Only a fraction of the drug in circulation will be bound, which means a fraction of the drug is free in circulation. So only free drug is active, and only free drug can cross membranes. So here I'm going to show you a picture. Here, protein-bound drugs are too big, so it stays in the blood. So protein-bound are these DP areas. Unbound passes to interstitial fluid. Unbound makes it in the equilibrium with the amount of unbound in the blood and the same amount in the intestinal fluid. So these Ds, I know you can't see on here because this was a video, but half of these Ds were here and then half were here in order to keep this in equilibrium. Water-soluble drugs got into the interstitial fluid, which is here in the middle, but then cannot cross into the intercellular fluid. Lipid-soluble drugs, however, made it all the way into the intercellular fluid because they pass more readily through cell membranes. Protein binding, bound drugs act as a reservoir. Only free drugs get metabolized and are eliminated. As free drug concentration decreases, bound drug becomes free to maintain equilibrium. So then liver knocks off proteins to the protein-bound drugs so they can cross over the membrane. This is to maintain equilibrium and why the liver is important. Some drugs distribute to and accumulate in specific tissues, such as tetracyclines in the bone, barbiturates in the brain, antifungals in the skin, and macrolide antibiotics in the lungs. These drugs will attain higher concentrations in that tissue than in the plasma. Drugs bound to tissue may or may not be active. Protective tissues, we have a blood-brain barrier, which has no pores. It has tight junctions between cells. There's no festrations in the capillary endothelial cells. It has a layer of astrocyte foot processes, and it can't go between cells, have to go through cells. So lipid-soluble, non-ionized, and unbound can get across. P-glycoprotein efflux pumps. Collies don't have this pump if they have the MDR1. Carrier immediate active transfer pump drugs out. They are present on the blood-brain barrier and other protected sites. The GI lumen decreases absorption as hepatic cells decrease metabolism. And MDR is a cancer cell. Other protected sites include the eye, the prostate, the placenta, and the alveoli. Significance of inflammation. Well, this increases drug permeation, it increases protein. Drug concentrations will decrease as inflammation decreases. Lipid-soluble, non-ionized, and unbound drugs, again, do best. Not just normal anatomical barriers, but you have abscesses and granulomas. And then pharmacokinetics of distribution, we have volume of distribution, which is the VD. We have theoretical volume of fluid into which a drug appears to distribute. We have the equation VD equals dose divided by the plasma concentration. Higher doses that result in lower plasma concentrations will seem to have a larger VD. So questions. A dose of a drug is dissolved in an ocean. Will the concentration in the fluid ocean appear to be high or low? So you put a tiny amount of drug into the ocean, will the concentration in the fluid appear to be high or low? Obviously low, because an ocean's big. If you put a tiny amount of drug in it, would it matter because there's so much water? No. Another question, the same dose of the drug is dissolved in a glass of water. Will the concentration in fluid in the glass appear to be higher or lower compared to the ocean? Well, obviously higher because there's not much water in a cup of glass. So then we were shown these. So the first picture, we have a dose of 1 milligram. We have a concentration of 4 micrograms per mil, and then a VD, and then VD equals dose over the concentration. So the VD here is 0.25 liters per kg. Here, all drugs stayed in the water, would stay in the plasma. So this meaning that the drugs would stay in the plasma, that they aren't being distributed out like they should be, so they can only cure infections that are in the plasma. Whereas the next one, the VD, is 1 liter per kg, so going up. So concentrations were lower due to the drugs starting to distribute out to the outsides, so distribute inside and outside of plasma, and so this means the drug can go out of the plasma and get into the cells because it's more widely distributed. And then lastly, we have a VD of 2 liters per kg. So what does that mean? The drug is gonna distribute more widely. So the peak The pharmacokinetics of distribution, we have the VD. So why do we care? A very small VD infers drug retention within the plasma. Again, this is everything I just went over, so I'm not going to go over it again. I didn't realize it was the same. So then we got into volume of distribution. So what can we say about the VD of these? So drug A compared to drug B here, what can we say about that? So assuming an equal, so which drug is more lipophilic, tend to distribute more widely? So if we were comparing drug A and drug B. While drug B is more lipophilic than A, assuming equal protein binding. What if we compared drug B compared to drug C? Again, assuming equal lipophilicity, which drug is more protein bound? So don't distribute as widely. So drug B is more protein bound than C, assuming equal lipophilicity. And then drug A compared to drug C, again assuming equal lipophilicity and protein binding, which one has a smaller molecular weight? While smaller drugs move more easily across membranes, so the answer would be drug C is smaller than A, assuming equal protein binding and lipophilicity. And then physiological factors affecting distribution, we have age. Neonates have more body water, so more interstitial fluid, so more distribution of water-soluble drugs. So more water equals a larger VD, which equals lower plasma concentrations of water-soluble drugs. Old people are shriveled and dry, so less water equals a smaller VD, and which equals higher plasma concentration of water-soluble drugs. So then we talk about weight again, but with lipid soluble drugs. So neonates have very little fat, so they have smaller distribution. So less fat equals a smaller VD, which equals higher plasma concentration of fat soluble drugs. Obese animals have lots of fat, so they have larger distribution of lipid soluble drugs. So more fat equals a larger VD, which is a lower plasma concentration of fat soluble drugs. Disease effects on distribution would be dehydration again, cardiac disease, renal disease, these diseases causing fluid accumulation, diseases that cause protein loss or protein loss enteropathy, protein losing nephropathy, and decreased albumin available to bind acidic drugs, so more free drug to distribute across membranes. And then we have diseases that cause increased protein, which is inflammation, increase the concentration of alpha-1 acid glycoprotein. It binds basic drugs. There's less free drug available to distribute. And then we have protein binding effects are probably more theoretically than clinically significant. Would have lost a lot of albumin, would need to have a lot of inflammation. So that was the end of the pharmacokinetics lecture. And then lastly, we had the small ruminant production systems, where we talked about sheep and goats. So there are 5.2 million sheep in the U.S., 3.81 are breeding. So what happened? We had a lot of sheep back then, but now we don't have as much. Their wool became less and less popular. Also, we don't eat as much sheep or lamb nowadays. Western states have higher populations of sheep and goats. Yeah. So we also had so again, goats, we had 2.6 million meat goats and 2.818 for breeding. Again, the western states have higher amounts of goats. We have milk goats and Angora goats that make cashmere and fiber. We have herd sizes which are similar to that of sheep. So we have to learn all the different kinds. So here we have Suffolk sheep, their main meat breed. They have clean heads, black heads, legs. Lambs are born black but then turn white. We have Dorset sheep, which are the top ones here. We have Finn sheep. I'm just going to show you all the different types because I'm not going to go through what they look like. We have St. Croix sheep. We have Barbados here at the bottom. We have Catadin sheep. Merino sheep. Those are the ugly ones that I think they're ugly. Then we have boar. We have Kiko. We have the Spanish goat. And then small ruminant meat production. Sheep have market lambs. They sell in stockyard or individual sales. We have market wool in whirlpools. And then we have pool animals, which are sold in stockyard or individual sales. Goats, however, have market kids, stockyard or individual sales, and they have coal animals, stockyard or individual sales. The meat market depends on the ethnicity, Caribbean, Middle Eastern, African. It depends on religious holidays as well. Reproduction and meat. Reproduction is by natural service. Rams or bucks are purchased from a registered breeder. The mainstream to purchase a yearling buck or ram. Bucks and rams are turned in with does and ewes at a rate of 1 to 30 females. Production meat, breeding season. We have seasonally polyestrous, so short day breeders, breeding starting in August or September all the way to December. Flushing ewes and does results in extra ovulations and increased lamb kid crop. Females are flushed for 2 weeks of increased feed. Then we have a male teaser, so they can put breeding synchronized, or when females go into ovulation to be synchronized. The length of the breeding season, sheep's are 28 days, where goats are 35 days. Breeding seasons are fairly compact. You put a crown on the male, so when they breed, they leave a stain on the female, so you know that they've been bred. Kidding and lambing occurs in the springtime. Goats, 150 days of gestation length, and then sheep are 145 days gestation length. It's desirable to have twins. May lamb kid indoors or outdoors depending on the weather. You may place the young and dam in a jug, which is the number of days in a jug is equals the mother. You count the mother and then how many kids she has. Goats usually stand and give birth, whereas sheep usually lay down. Kidding and lambing continue. Lamb weighs about 6 to 12 pounds, whereas a kid weighs 5 to 8 pounds. Kids and lambs are susceptible to starvation and hypothermia. Castration is during the first 2 weeks of life. Wethers, sheep tail docking, and goats dehorning. Weaning, peak milk production at 3 to 4 weeks. For meat animals, wean usually around 12 weeks of age, so 2 to 6 months. Lambs are usually 40 pounds, kids are usually 35 pounds. Post-weaning, you have replacements. Slaughter, 6 to 8 months of age. Lambs, 130 pounds. Kids are 80 to 100 pounds. They're fed pasture with possible grain. Sheep may go to a feedlot. 70% are fed in colos. Goat fibers are usually cashmere or mohair. Cashmere is the undercoat, combed out in the spring. Mohair is shorn in September and March. So we have to learn dairy goats as well, so I'll show you these. We have the Alpine here. We have the Saanen. We have the Toggenburg. We have the Nubian. We have the La Mancha. And then we have the East Frisian sheep. So then we got into dairy, reproduction the same. Lamb and kids are separated at birth. Females are milked 2 times a day, on average 1,800 pounds, at E being at 600 to 1,200 pounds. They're milked in a parlor, and a milking unit usually has 2 teat cups. Some small ruminant problems are internal parasites, labor, predators, marketing, so slaughter facilities, and seasonal breeding. It's best to eat lamb in summer and fall. Sorry I got through that really fast. I'm trying to get some rest because it's before tutoring, but hopefully none of that stuff was really complicated. But we got to learn a lot of cool stuff today. But I love you guys, and I thank you guys for watching, and I also hope you guys had an amazing Tuesday. And yeah, I will talk to you guys tomorrow.